when I read a little bit of the bio of the next speaker, who did his medicine at Albert Einstein, so we have something in common there. Pediatrics at the University of Pennsylvania, P-Derm Fellowship at CHOP, now the pediatric dermatologist at the derm section at Children's Hospital, and associate professor in peds at derm at Perelman at the University of Pennsylvania. And then get down to the part, professional highlights, and it's really very nice to see someone who has had so many teaching awards, Teachers of the Year, Resident Teaching Excellence as a faculty teacher. It's, for we who've made a life in academics, that always has tremendous impact. And interestingly, several of our residents put in a request to have Jim Treat join us this year. So we listen to our residents. They know what they're talking about. We have Jim Treat as our next speaker. James Treat will speak on hair and scalp disorders in children. Please welcome him.
I'm good. All right, thank you for having me. Cool, I'm just gonna get situated up here. So trying to speak on hair and scalp disorders and saying something new without talking about alopecia areata is like a little challenging. So you're gonna hear a ton about alopecia areata tomorrow, so I'm gonna basically just skip that topic essentially entirely. And then can I just get a show of hands? How many people are pediatricians? Cool. And then how many people are dermatologists? And Dr. Schachner, you get to count twice. That's awesome. Okay, cool. So, so I tried to also include things that are relevant to both groups and then some unusual things also. So some things that are kind of tips and trips for clinical practice as well as some unusual things. So I have very few conflicts of interest. So this is a kid who came to see us who's 6 years old, who comes in with a very thick crust on the scalp and has a negative fungal culture. And honestly, I looked at it, and Albert Yan, who was my attending at the time, was like, I think you should debride it because we need to see what's under it. And I was like, I don't really know what's under it. It might be brain. And so with trepidation, we soaked it a lot and we got the crust off of there. And this child had not been treated with an antifungal because of the fact that they'd had multiple fungal cultures which are negative. So if you live in the world of dermatology, this is a thing. If you have a carry-on, it's extremely inflammatory. You get negative fungal cultures all the time. And you basically just have to treat based off of what you think is your clinical impression. And we'll go through a little bit of this in terms of how to differentiate. It's certainly possible for that to have been staph infected. If you look at the person on the left, they're oozing and weeping. They have a huge kind of foreign body reaction against the fungus that's in there and some of the hair follicles that are in there. And culturing for Staph aureus is never the wrong answer. If you find some Staph aureus, it's nice to treat it because you can kind of get things better, a little less inflamed very quickly. But just kind of remember all your different forms of tinea capitis. So you've got your black dots, you've got your kind of broken hair with scaling, and then you've got your boggy carry-ons. And every once in a while, someone just has like a seborrheic look. So they have like a lot of scaling in their scalp. They don't have a whole lot of hair loss. And we culture and we find a dermatophyte in there. It's hard to know whether they're actually just colonized or whether they're truly infected. But if they are colonized and they've got scaling dermatitis in their scalp, it's reasonable to try to treat them. So just some kind of like tips and tricks. I'm sure people have treated tinea capitis quite a bit, but these are some pitfalls that I've kind of gone through in my career. A couple things. Griseofulvin only works with food. So, and if you look at the griseofulvin versus terbinafine trials, which it's possible Beta Abair actually did, so I will actually ask in case I say something wrong. But if you look at them, they did some head-to-head trials where they compared griseofulvin, at least in some of the trials, that was at 10 to 20 milligrams per kilogram with full-dose terbinafine. And those trials are a little bit unfair, and that may not have been the one that Beta was part of, but they're a little bit unfair because we typically will use griseofulvin at 20 milligrams per kilogram up to 25 milligrams per kilogram. And I find that griseofulvin usually works. The downside to griseofulvin is you do have to give it with a fatty food. If you don't give it with fatty food, it truly does not work. Terbinafine works really nicely and is FDA approved down to 4 years of age. And then one of the potential pitfalls that you may not have realized is that if you mix it with applesauce, it actually does not work. So applesauce actually deactivates it. That's actually in the package insert. The very first patient I gave terbinafine to as a fellow, I totally mixed it with applesauce and couldn't figure out why they weren't getting better. And then the other question becomes kind of what do you do for tinea capitis that's in children who are under 1? So a lot of them have hair follicles that are not very well matured, and so they don't have quite as many terminal hairs, and so you may actually get away with topical medicine, but kind of an oldie but goodie drug that you can actually use in children under 1 is fluconazole, and remembering that fluconazole is in your armamentarium is very helpful, and it's about to become very helpful with another patient that's totally in my second talk. I'm going to give it a little bit on tinea in the second talk also. This is a patient who comes in and they have, if you're looking from a pediatric standpoint, you're like, man, they've got a lot of tinea, but there's no scaling, there's no black dots. It looks like the skin was kind of completely normal in the background, and this is alopecia areata that you're going to hear a lot about tomorrow. But this is alopecia areata and tinea next to each other. And I often give people with alopecia areata a chance to have tinea. I used to say I'm terrible at treating alopecia areata. We're actually now pretty good at treating alopecia areata because we have a lot of good options. But we're really good at treating tinea, and it would be really nice to find tinea in someone who has a couple of patches of hair loss because we're much better at treating that. So I often will give people the opportunity to have tinea by essentially doing a culture, and if there's any question at all. The other question we get a lot is like, oh my gosh, it's a carry-on, but it can't be a carry-on because it's someone who's got like long straight hair, and that's absolutely not true. So you can absolutely get carry-ons in people with long straight hair, and so it's important to kind of be able to recognize that. That's cool, the clock just went from 20 minutes to 17 minutes. I was wondering whether like time was standing still and I was just hanging out up here. All right, so again, in terms of kind of like newish things, this is a 10-year-old who comes in and they have just a bizarre pattern of hair loss. So there's two different versions of trichotillomania. There's the 2-year-old who's sitting there who's literally like pulling their hair while they're in the office because they're nervous seeing you, and you're like, you have trichotillomania. And then there's the teenager who comes in with like bizarre hair loss, and they're like, I've never touched my hair ever. I didn't even know I had hair. I'm not pulling at it, not doing anything, and the parents are like, they're definitely not doing anything. And like, you know how apple trees make apples? Like often the parent's sitting there like picking at something and they're really nervous about the visit, and the child has had some trichotillomania. So hair pulling gives you these bizarre patterns in the hair. You just look at it and you're like, that just doesn't look like it should have happened from a normal process. And then often you'll see regrowth in the areas where the kid will kind of pull in an area and then kind of like work back. A couple of clinical pearls. It's very hard to pull your lower eyelashes out. It's very easy to pull your upper eyelashes out. So when you see people who have trichotillomania on the eyelashes, don't try this right now, by the way. Usually people are like, usually you're going to have more upper eyelash involvement and less lower eyelash involvement. And then Band-Aid sign is a really nice one also, where essentially if you do a biopsy, which we try not to do, but if we do a biopsy, you'll see the hair kind of grow right back right underneath of the biopsy. So this actually came out a long time ago, and it was talking about using N-acetylcysteine as a modulator in trichotillomania. But the cool thing is this actually works with almost all habit tic deformities. So we looked at 1,000 patients at CHOP, and this data is actually not published yet, so I didn't put it in there because it's kind of in press and I can't remember the rules. And essentially what we found in the like 120 patients where we could see what actually happened with their N-acetylcysteine given as an oral medication, it seemed to work for every version of a habit tic deformity. So people who are needy and nail deformity because they're picking at their nails, people who are biting at their skin, people who are picking at their hair, people who are picking at their acne. N-acetylcysteine is a really nice thing to have in your armamentarium. It is a pill. It's a pretty big pill. It was a fake COVID therapy, so because of that, it was actually taken off the market for a little while. So if you have patients who say, oh, I can't get it anymore, it's now back. Amazon banned it for a while, but it's now back. And the improvement in multiple clinical trials for multiple different habit tic deformities has been really good. And we looked at a really large group of patients and found that the same thing was true. So I like to use it especially in these patients who they come in and you're like, I think you had acne, but you literally ripped your face off, and I can't find any acne anymore, but I can find all of the crusts and erosions. It's a really nice adjunct to say, we're going to slowly give you some like adapalene and benzoyl peroxide and maybe some doxy, et cetera. But in the short run, we're going to have you treat your skin nicely by not picking it as much. And oral N-acetylcysteine, again, off-label, is a reasonable way of doing that. So this is one of the original trials for excoriation disorders and talked about doses from 1,200 to 3,000 milligrams. Again, off-label, but it's an over-the-counter medication. It's not something you can actually even prescribe very easily and works for lots of different things that are habit-tic deformities. All right, just very briefly, telogen effluvium, just because you can't give a hair loss talk without talking a little bit about telogen effluvium. Telogen effluvium is super common. This is usually, again, for our pediatrics audience, this is going to be the person who comes in and they had some major stressful event 2 to 3 months beforehand, and they start losing their hair diffusely. So they're losing hair kind of all over. They're not getting individual patches of hair. And when you take it out and you kind of put it against your black shirt or something that's dark, you can actually see the little bulb of hair that's there that are telogen hairs, and we expect regrowth to happen in 6 to 12 months. That being said, sometimes this is the kickoff for the older child actually having some androgenetic alopecia, and so often things like topical Rogaine are used off-label to help people with telogen effluvium. Just a kind of like quick, basic how to diagnose common alopecias. You generally can divide alopecias into diffuse and localized, as well as scarring and non-scarring. So non-scarring alopecias are going to be your like telogen effluvium, occasionally lead poisoning, where you kind of are just losing hair all over, potentially failing to thrive, or your localized alopecias, where you're going to have alopecia areata, trichotillomatosis, tinea capitis. And then your scarring alopecias are going to be worse. So they're going to be your lupus or your something called folliculitis decalvans or dissecting cellulitis, or potentially a carrion. All right, this is a 2-week-old who came to our emergency room who had crusting going around the back of their head and essentially came in because they were worried that there was an infection there. And you look at it, and this child has a scar perfectly around the very back side of their scalp and essentially has complete hair loss in those areas. This comes up in various different situations in clinical practice. So this one is called a halo scalp ring. So it turns out that your scalp is fairly moldable in the beginning part of life in order to be able to get out the vaginal canal. And when you're coming out of the vaginal canal, it needs to kind of become like a little cone head in order to get out, and then it kind of goes back into normal. But the places where your scalp is very hard are the back and the occiput of the scalp. And that occiput area can get pressed against mom's pelvis, and when it gets pressed against mom's pelvis, you can get fat necrosis. And if you necrose the fat, you can end up with hair loss that shows up either acutely as a ring of erythema and potentially fluctuance and potentially crusting, or later it can show up as scarring. The other group for whom this happens, which is a little bit can happen in any age, is people who've undergone cardiothoracic surgery. So we get consults all the time for people who have had like the 10-hour surgery where they've gone and like remade a ventricle in a child. And they come out, and a few days later, they'll notice some alopecia on the occiput of the scalp. And that occiput is often a little bit red, and then eventually you get a little bit of the, sometimes crusting, and then often a little bit of hair loss there. And we have families who are like, oh my gosh, my child has like a quarter-sized piece of hair loss, and we're like, yeah, but your child's alive, so this feels like a good trade. You can't always move people when they're under ECMO in cardiothoracic procedures, and they're doing all of the things that you learn about that are associated with fat necrosis. They're getting cooled in the OR room, they're hypoxic, they're having chronic pressure, they're not moving around. It's every single risk factor for having some fat necrosis. So keep an eye out for that as you are evaluating people potentially as inpatient consults. So this actually was an impressive halo scalp ring because it actually went all the way around to the front. And again, she was admitted, you can see a little bit on the left here. This is kind of a few days later, but you can see a little bit all the way on your right, actually, where there was a little bit of crusting and kind of that inflammatory response. And that can happen with subcutaneous fat necrosis, where it breaks open to the surface and it's basically just oozing a serosanguinous fluid. This is another halo scalp ring in a child who's a little bit older who comes in. Children, in case you've never thought about this, children do have hair loss often in the back of their scalp, which we think might be from one of two things. It may be kind of the child's version of a telogen effluvium when they come out. So you'll see 5, 6, 7-month-olds who have like an area of hair loss usually on their occipital scalp. But some of that may be because they're kind of laying down and they're not moving, and there may be some pressure orientation for that also. Cool. All right, so this is probably the most important one to recognize, but also one of the less common, although uncommonly recognized. So this is a child who comes in and has inflammatory bowel disease. They could also have JIA. They could have chronic non-infectious osteomyelitis, or CNO, also called CRMO. And the common denominator for all of them is that they got put on a TNF-alpha drug. So historically, when I was training, we didn't have any systemic drugs for psoriasis besides cyclosporin and methotrexate. And then the first round of real systemic drugs besides alefacept and a couple of random ones, was TNF-alpha drugs. And so they had infliximab and adalimumab, and they treated psoriasis pretty well. So they were really good psoriasis drugs. And then we've kind of moved on to other more targeted therapies for most of our patients with psoriasis. But the reality is that TNF-alpha drugs are used really commonly for patients with idiopathic arthritis as well as for inflammatory bowel disease. And so when people started getting this kind of like crusting in the scalp, it was a little bit unusual because it doesn't look like just straight up psoriasis. This is an extremely inflammatory version of a scalp dermatitis. And so you may be used to the idea that TNF-alpha drugs can actually cause psoriasis through a kind of a paradoxical mechanism. But that paradoxical mechanism in children often shows up in the scalp with a much more inflammatory version of psoriasis than you're used to seeing with like regular psoriasis. So regular psoriasis in the scalp, it's like annoying and it's scaling and it's red and it causes some dandruff appearance. The TNF-alpha version of psoriasis, which is driven by the TNF-alpha drug, causes much more inflammation. It tends to cause a lot of hair loss. It can cause ulceration, oozing, really a look that really looks like it should be really bad tinea capitis or a really bad carry-on. But it's important to kind of have this in your differential. Often people will have kind of a seborrheic component behind the ears. Often they'll have a little bit of inverse psoriasis, sometimes in the groin, but sometimes it is just the scalp, and sometimes it's bad enough that this actually warrants changing off of the TNF-alpha drug, even if someone's bowel is in really good shape. So this was one of the original reports now 10 years ago by Marissa Perman, who's actually at CHOP now. And essentially, they proposed that ustekinumab would be a really great treatment because ustekinumab at the time was not approved for inflammatory bowel disease, but it is now approved for inflammatory bowel disease. So you can switch someone to a pure psoriasis drug that also treats inflammatory bowel disease off of their TNF-alpha drug, and that's really helpful. Has anyone had this fail? So I'll just ask that rhetorically. I've had this fail. So we've had a bunch of patients for whom ustekinumab does not work. And I think the next best therapy beyond that becomes JAK inhibitors. So the answer to pretty much everything in dermatology right now is like JAK inhibitors. But in like 5 years, it's going to be like, oh my gosh, JAK inhibitors, and then there'll be something else. But right now, JAK inhibitors are all the rage. They are a reasonable option if you have to switch someone off a TNF-alpha drug, if you can't get an IL-23 or an IL-12/23 covered, because those drugs are going to treat IBD and psoriasis. Also, JAK inhibitors do the same thing. And this is, again, for our pediatrics audience, this is called paradoxical psoriasis because you're giving a drug that should treat psoriasis. You shouldn't get psoriasis after you give someone a really good psoriasis drug. And this can happen anywhere from like a few months to up to 10 years after you originally start the drug. So you have to keep your head a little bit on a swivel because of the fact that this can happen after a long period of time of being on the medication. In looking at it, we looked at our JIA patients, which was a few hundred patients, and found that it was 4 to 8% of them actually ended up with some version of psoriasis. This is not uncommon. And this is something that you'll certainly see in your practice if you're seeing patients who are being treated with these systemic drugs. The idea is that there's an escape pathway, and you basically get upregulation of plasmacytoid dendritic cells, and so it's not a pure psoriasis pathway. And most of the patients, when you stop the TNF-alpha drug, actually do improve. And you don't always have to stop it. Sometimes you can just kind of give them good topicals and they can get a lot better. But if they're getting a really inflammatory version, often they'll get worse with each dose that they actually give. Cool. So bottom line, hair and nails, I put nails in there. I wasn't supposed to talk about nails. It was supposed to be hair and scalp. It just rolled off my tongue when I was writing it. Sorry. So tinea capitis pretty much always requires systemic therapy. Unless you're under 1, there's a chance that you can actually get away with using a topical azole. Alopecia areata and telogen effluvium are often triggered by major stress events, and you're going to hear a lot more about alopecia areata tomorrow. And then TNF-alpha-induced psoriasis mimics infection. It mimics like a severe carry-on. But you have to make sure that you're kind of thinking about the TNF-alpha drug. Even if they've been on it for 5 years, it can actually be the cause. So thank you.